I guess I should have the camera on me. All right, so here's the Gastric POCUS presentation I've put together over some time. So the IM framework is kind of recommended by Astra when approaching patients and with any kind of gastric scan. So the idea is to, of course, first come up with the indication, then acquire the images, interpret them, and then use some medical decision making to figure out what to do next. And this grading system is validated in children, obese patients, non-obese patients, and obstetric patients. So the indications, so to risk stratify, right? So when gastric content is uncertain based on clinical information alone, so unconfirmed fasting history, patients who are pediatric, there's a language barrier or there's an altered mental status, or patients with severe comorbid systemic diseases affecting gastric emptying, so diabetic gastroparesis, end-stage renal or liver disease, neuromuscular disease such as Parkinson's. And then, of course, emergency situations where delayed gastric emptying is common, despite otherwise appropriate fasting adherence. So again, the idea here is that it does not replace NPO guidelines at all, period, full stop. It is only used to risk stratify a patient, help you make the determination whether you can proceed with an elective case or if you're going to proceed with an emergency or urgent case, whether you'll do a pre-induction NG tube, RSI with head-to-bed elevated, etc. So the gastric antrum is in a consistent location, which is what makes this such a easy technique to learn. You want the patient in two positions to do a truly authentic, verified gastric scan. You're going to start with them in the supine position, and then you're going to have them turn into the right lateral decubitus position. And that's so that all the gastric contents shift towards the gravity-dependent antrum. And you're going to want to hold the view for 10 to 15 seconds in each position because peristalsis can dramatically change the antral size. So you're going to look for essentially three things every single time. You're going to look for the liver edge, which you can see. Let's see if I can get this thing in here. I'm not sure which one you guys are recording up. Here's your liver edge. You're going to look for your aorta in the far field, okay? And then you're going to see your multi-layered wall adjacent to the liver edge. So I always first find the liver edge. Then I look, deep into the picture, look for my great vessels, and then I kind of wait for peristalsis. This is literally, you're going to scan the epigastrum in the sagittal plane. You're going to sweep from left to right in the subcostal margins. Typically recommended to use a curvilinear low-frequency probe, but you can use a linear probe in skinny patients or pediatrics. This is kind of where you're going to slice through with your scan. So again, this is the parasagittal position of that probe, and this is what you're going to kind of slice through. As we look at this, we're looking at the antrum. So again, the antrum, you have the body of the stomach. This is the antrum, and then you have the pyloric canal, and then it dumps into the duodenum. And the important thing to remember, of course, is that we want to find the great vessels and identify the aorta so that we know that we're over top of this antrum, okay? Because if you confuse it for the pyloric canal or the duodenum, but typically the pyloric canal, you would see the vena cava in the background, okay, and not the aorta. All right, and we can show this a little closer here. So as we pull the stomach out, you can see here's the pancreas. And then here's the aorta. So we want to be over top of the antrum here in the aortic plane, not over top of the vena cava, which would show us the pyloric canal, which is artificially small and can give you false reassurance. So just be careful with that. So here's the vena cava. And initially you can see, of course, like this, here's this liver edge. Here's this great vessel in the background, looks pulsatile, and then here's the stomach, right? Kind of reassuring, right? But this is actually the vena cava, not the aorta. Now, if I scan the probe over, now you see the aorta. So it goes from vena cava to the aorta, and the aorta truly is pulsatile. You know what I mean? You can apply your pulse wave Doppler to actually trace those waves out. And then you can see in this image that actually this has got some food in there. I mean, this is actually a full stomach. So you could have been, falsely negative. And then we can apply color, and color wave is a type of pulse wave Doppler, and you can actually see the SMA come off, right? So this is actually the aorta and the SMA, and that's how one good way to differentiate between the aorta and the vena cava. The vena cava will have a 90-degree intersection with one of the portal veins. The aorta will have this kind of off-ramp looking thing, kind of lies off, right? And that's your SMA, your superior mesenteric artery. So limitations, patients who've had, gastric resection or bypasses, gastric band in situ, fundoplications, large hiatal hernias, these patients, not very reliable. So practice or advance with caution. And then how do we interpret this? So you got your images. You can do a qualitative assessment. So is it empty or is it full, right? And then if you do see something in there, is it food or is it liquid, right? So remember, liquid on any kind of ultrasonography is always going to be dark and black. Food will be kind of, heterogeneous and kind of look like gray, squishy matter. Or we can quantitatively assess it, okay? And there is a volume calculation, okay, that we can use, all right? And this is kind of the algorithm you should have in your head, right? So put the patient in supine position first, and then turn them into the right lateral decubitus position after about 15 seconds or so. And if you don't see anything in there, that's an empty stomach. Congratulations. Move forward. If you do it in supine and right lateral decubitus and you see solid food, this heterogeneous, kind of nasty mush, that's solid food. There's food in there. That's a full stomach. Proceed, as if they are, a full stomach, because they are. If you're in between, if you can't quite tell, or you see just fluid in there, about, I think it's somewhere in the ballpark of 30 to 50% of patients will present with a normal amount of fluid in their stomach. That's just normal gastric secretions. The threshold for kind of empty versus non-empty is 1.5 mLs per kilo, but it's not just a simple, straightforward solution. This is actually the regression equation that they derived in 2017. And this is the one that's used and recommended. And so you don't need to do the math. There's actually a table for it. It just goes, one thing to include in there is to make sure that you're aware that that age is a big part of that as well. So here's how we're going to do this. We're going to obtain the antrum at the level of the aorta in the right lateral decubitus position. We're going to freeze the image, and then we're going to trace, okay, the CSA, the cross-sectional area, okay, including the gastric wall. Remember, it's multi-layered, and then you're going to use this table, okay? So notice how they've paused the frame. They've drawn this circumference. This is the cross-sectional area. And then you see the top left corner, the ultrasounds will always auto-calculate this for you. And it'll tell you how many centimeters squared that is. And they've included the wall, so just remember that. And then here's this table, okay? So again, you have the cross-sectional area on the left-hand side of the table, age across the top. Anything in green is considered safe, right? So again, if you have a patient who is slightly older, there might have more, benign liquid in their stomach compared to a younger person. But anybody who's got a cross-sectional area greater than about, whatever it is, 10 or 11 centimeters squared, that's a full stomach. So, it's a good threshold to know. If it's greater than 11 centimeters squared, you got a full stomach no matter what their age is. Anything greater than, 6 should really make you start thinking whether this patient's got a full stomach or not. They grade it, grade 0 all the way up to 3, or really it's grade 0 up to full, grade 1, 2, and full. This is a grade 0, right? It's completely empty. The stomach's contracted and tight. It's that kind of classic donut sign. You can see the liver edge, you see the aorta in the far field, and then you see this multi-layered wall just adjacent to the liver edge. Okay. So again, aorta, liver there. We have the aorta in the far field. Okay, and then we can see this nice multi-layered wall right there. Okay. Grade 1 or 2. Okay, grade 1 or 2 just depends on the volume itself. All right, grade 1 or 2 means that there's liquid in there. You don't see any solid food, but you see liquid. And a grade 1 is normal, right? That's just normal gastric fluid. It's less than 1.5 mLs per kilo based on that calculation in that table we looked at. Safe to proceed. Grade 2 is an actual full stomach, okay? So this is what a grade 2 looks like, okay? And what you actually see here is what's called kind of the starry sky sign. Is you see how that anechoic stomach is filled with these kind of little dots of light. And that's actually air bubbles. So that means it was recently consumed, probably, because we all drink and swallow a little bit of air while we're consuming liquid. So that is a full stomach. That's a grade 2 full stomach. And again, you can see liver edge, aorta in the far field. Here's the pancreas, and then just above it, right adjacent to liver, is the stomach. This is food, So this is just a full stomach. All right. You got your liver edge. You got your aorta in the far field. You got your pancreas here. And then here's just kind of heterogeneous kind of mush that's there in view. And so that's another kind of still picture of a full stomach, okay? Again, just going to say it again. Liver edge, aorta in the far field, pancreas in between, this multi-layered wall right up against that liver edge. So let's see here. This is immediately post a meal. And so what I want to do highlight here is kind of this acoustic shadowing. So this very bright edge here is food that's essentially blocking the ultrasound from getting good images deep, right? Because all of that's reflecting there against that food. So this is, acoustic shadowing immediately following a meal. And again, you can see this is what a solid meal looks like, right? It's food moving in there, literally being peristaltic. So again, we'll say liver edge, aorta in the far field, and then you can see this multi-layered wall right there against it, and it's just peristalsing and just crushing up that food. And so that's a very clear full stomach. We talked about this one before, right? That we had kind of seen liver edge, this pulsatile vessel back here. We're not really quite sure. It might look like we got this kind of multi-layered, small contracted wall here. But again, if you notice that it's actually the IVC. All right, so here's a grade 0 again, right? Antrum, SMA, liver edge, aorta. Here's a full stomach with the acoustic shadowing. Here again is a full stomach. See the multi-layer wall full of that stuff in there. Aorta in the far field. This is a grade 1 or 2. We'd have to do a cross-sectional area calculation on that, where we freeze the frame, draw a circle around the antrum itself, and again, using the device itself and including the multi-layered wall. This is likely a grade 1, could be a grade 2. Do you see the starry sky? So it means they may just drank something, maybe took a swish of water with a pill or something in pre-op. All right, so getting to the medical decision making, this is pretty straightforward. Right now we know if it's full or empty, right? The risk of aspiration. We can make some determinations based on whether it's an emergency case, an elective surgery, risk factors, and if there's alternatives. If you can just keep the patient awake and do a block. And I just have a couple practice slides in here so that you guys can all see. So obviously this one's an empty stomach. Okay, this one here is it's got fluid in it, so it's either grade 1 or grade 2. Looks like they kind of wrote here 250 mLs of liquid on that one. This is a full stomach, obviously. You can see it right there against the adjacent wall. This one here is also full of food. Let's see here. This one here has that acoustic shadowing. So here's the liver edge, here's the stomach, and here's the aorta. And again, this is full stomach. This is probably a grade 2. Again, liver edge, aorta in the far field, and then you have this big, dark anechoic antrum. So very likely fluid in there. This one's likely food again. So I'll say it again: liver edge, aorta in the far field, and then you got that multi-layered antrum right next to the liver edge, full of food. Oh, this is actually a good one. So this is actually one I had on a patient myself that I was a little confused about. So she's really, really skinny, this patient. So looking here, you see the liver edge, right? And then you see this, but there's this kind of gap there. And you're not really quite sure what you're looking at, right? And very tempting at first. Let me pause this and bring this back. Very, very tempting at first to say, whatever this thing is moving right here, this is full stomach, right? That's got to be the full stomach there. Here's my liver edge. But what I will ask is, where's your aorta in the far field, right? So as we keep watching this, I move the probe, and now here's your aorta. Now watch that thing just pulse, you know what I mean? You can see it's just a pulsatile aorta right there. So I'll go back to that view. So here's our actual aorta, right? And then you notice the stomach's right here. So she's actually a grade 0, right? She's an empty stomach. What this was is actually her colon moving stool. So be very careful to make sure that you find your landmarks. Liver edge, aorta in the far field, and it needs to be adjacent to the liver wall. Having this huge gap here and something peristalsis over here, you're going to get confused and may think of that as being a full stomach. And then here's another example I have of somebody who, took a view of and mistakenly had the IVC in view at first, right here, and it doesn't really look that big. And then as you move across, you can see it's just full of fluid here. Anyway, I hope that all helps, and see you guys at work.